Good morning, everybody. Welcome to our Cardio Echo QI Cardiovascular series. We're excited to have you here. As just a reminder, this is all about QI, and we're excited to hear about your projects. Next slide, please. So just as a reminder, was founded in 2017, and the mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. It's an initiative of healthcare professionals across all 7 medical schools, and we identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. And we do this through a variety of efforts, including our app, monthly newsletters, podcasts, webinars, and quality improvement using this Echo virtual training model. Next slide. So our agenda today is to do an introduction or getting started with QI. We're focusing on adaptive leadership today. Then Dr. Rao will go over a clinical pearl and lead us in a case study discussion. And then Amanda will facilitate site report outs. And then Andy will remind us of what we all have to do next. Next slide. As a reminder, these are our 6 participating sites from across the state. We have Erie County Community Health Center, Fisher-Titus from Norwalk, Metro Health, Middleburg Heights, the Village of Healing in Euclid, East Liverpool City Hospital in East Liverpool, and the Healthcare Connection in Cincinnati. Our project leadership are, so the cardio co-PIs are Dr. Constant and Dr. Bolin. I think they're both on the call. And then for this particular initiative, I'm co-leading it with Dr. Rao and Amanda, who's our QI coach. And then we would not be able to get anything done without our amazing project management staff, Andy and Claire. So thank you, Andy and Claire. Next slide. None of us have any disclosures. If you're interested in CME, there's one category, 1 credit available for this clinic. If you want to opt in, email Andy or chat her during this clinic, and she'll add you to the email list, and then you'll automatically be opted in for all future clinics. You need to complete your CME evaluation by September 5th. If you don't receive the email, contact Kathy Sullivan, or you can reach out to one of our project managers as well, and they can help you get set up with the email. Next slide. So our learning objectives for today, as I mentioned, we're talking about adaptive leadership, differentiating between technical and adaptive challenges in QI initiatives, describing the key attributes of adaptive leadership, and identifying practical tools and approaches to manage the cultural and emotional and organizational dynamics involved in implementing change. Next slide. Just a reminder, please do not share PHI if you're sharing examples. Next slide. I think I already talked about this. I think you all know who I am, so I'm not going to introduce myself again, but nice to see you all. So what is adaptive leadership? So adaptive leadership represents a fundamental paradigm shift from leadership as an individual responsibility to a social and collective process. It's an ethos that Eifetz and Linsky, who are from Harvard, and others have described as leading without authority. So you don't necessarily have to be in a leadership role to be a leader, is what they're trying to say. It might sound counterintuitive, but in this model, leadership isn't about exercising power over others. Rather, it's a responsibility bestowed upon a leader so that they can help a team overcome nuanced challenges while keeping everyone's best interest at heart. Next slide. Okay, there's a lot to unpack here, so this is going to take me a minute. So there's really some important key aspects of adaptive leadership. So this slide outlines the essential behaviors and mindsets that define adaptive leadership. These qualities are especially important in healthcare and community health work, where change is constant and challenges are complex. So when we talk about embracing change, adaptive leaders recognize that change isn't something to fear, it's something to harness. In healthcare and community work, change is inevitable. New policies, shifting patient needs, and evolving data, and leaders really must model openness and agility. We talk about mobilizing others. Effective leadership isn't about doing it all yourself. It's about empowering others to contribute to problem solving. In practice, this means including frontline workers, patients, community members, anybody who really is affected by the process in decisions that affect them. You want to focus on learning. Adaptive leaders focus on both what success and focus on success and failures as learning opportunities. And I often tell my QI teams that, it's amazing when you're successful and when you meet your goal, but we learn a lot more from not meeting our goal and understanding what the process is and where our failures were and, how we can improve upon those. So we focus on what worked, what didn't, what can we do differently next time. It's about growing forward and not blaming. We also have to address complex problems. Some challenges don't have clear-cut solutions, like reducing healthcare disparities or increasing engagement in care. Adaptive leadership really helps us hold space for complexity, experiment, and iterate towards solutions. Adaptive leaders have to demonstrate flexibility and resilience. Resilience isn't just about bouncing back, it's about adapting and thriving amid disruption. Adaptive leaders stay grounded, adjust when needed, and help others do the same, especially during uncertainty. It's also about collaboration and teamwork. Adaptive leaders thrive in environments of collaboration. No one can solve adaptive challenges alone. You have to build trust, share leadership, and align around a common goal. Align around common goals that are essential. So just these principles are not just for people with formal titles. Anyone within a system, whether a community health worker, a nurse, a clinic administrator, can practice adaptive leadership. It's about how we show up and respond to challenges and change. So the one example I have is many, many years ago, we were working on improving breast cancer screening rates. And I had a patient service representative who was on our team. And she said, I don't really understand why I'm here. I don't feel like I contribute. I'm not a physician. I'm not a nurse, and we talked about, how, she's the person who sees the patient when they come in and when they leave. And so her role is really important. And by the end, she had really embraced her role. And she actually wrote a poem about why it's important to get breast cancer screenings. So she really became the leader of the group, even though she was not in a leadership position within the actual clinic. So just keep in mind, those leaders can emerge from, just about anywhere. Next slide, please. So once again, this model was developed by Heifetz and Linsky at Harvard. And it really distinguishes between technical problems, which are solvable with expertise, like, becoming a surgeon or writing a prescription, versus adaptive challenges, which require mindset, behavior, and relationship change. Leaders often mistakenly apply technical fixes to adaptive problems. So we think that by working harder and motivating, and putting in technical solutions, we can solve problems. So if we put in a reminder in the EHR, that's a technical solution that may not actually that may require an adaptive solution instead. And I'll get to that in a minute. Next slide. So here's just some examples of challenges in cardiovascular disease. So a technical challenge is reliable identifications of patients with LDLs over 160 and effectively incorporating blood pressure control into workflow. But some of these things may be, okay, if we identify patients with LDLs over 60 and we want to put them on medication, they may have distrust of medication or the side effects. When we think about how clinicians may struggle through this, a lot of times they feel like we've done it this way. We think it's working, so why would we change anything? And then, as we're all aware of, social drivers of health, including unstable housing, limited access to healthy food, or low health literacy, can really impact patient outcomes and our quality improvement efforts. Next slide. So when we think about adaptive leadership in cardiovascular care, some things we can talk about are shared decision-making, about self-monitoring of blood pressure between providers and patients. What does that look like? How often should we take readings? When and where? What device? How to record and report? We could pilot the shared decision-making tool for antihypertensives, and then really ask ourselves, what keeps patients from engaging? What keeps providers from engaging, or other healthcare team members from engaging? And we can encourage things like pharmacy-driven blood pressure protocols, but a lot of people are scared of shifts, role shifts and liability, or just change in general. So those are things we need to keep in mind when we're talking about adaptive leadership. A lot of people tend to be change resistant. Next slide, please. So why do quality improvement projects fail? A lot of times they fail, as I mentioned before, is we have we underestimate our adaptive work. So many barriers to effective, for example, diabetes management seem technical, like updating EHR templates or improving lab result tracking. But the real lasting change often depends on adaptive work, such as changing beliefs, workflows, and team norms. An example might be adding a technical example might be adding a diabetes foot exam checkbox in the EHR. But the adaptive problem is getting all the providers to routinely perform and document these foot exams despite time constraints and differing habits. So I'm going to stop here for a minute and just ask a question. And just if you want to chat in or unmute, that would be great. What challenges in your clinic feel technical, but are actually adaptive in nature? And how do you distinguish between the two? Any thoughts?
Hey, this is Amber from the Village of Healing. I feel like this is an ongoing conversation that we as a team constantly have, and I love that you helped me put words to it. Like yesterday, I had a call in a patient. She was very frustrated because she believed she was calling into our office multiple times and no one was returning her phone call. Um, but in reality, she never left a message and she was expecting us to answer the phone right away and get back to her right away. And we have said protocol that it takes about 24 to 48 hours to return the phone calls, like from the nurse's office station. Um, as a team, we were kind of discussing this and really got kind of in a, like, I guess, a tenuous conversation, because then it turned into, well, you guys aren't doing your work kind of thing. And so we left everything on a positive note. But the reality of that is, we identify that we're busy, we're seeing patients in real time, and we can't always be available to answer calls or, be productive in answering those calls. But also there is downtime that we should be putting effort to returning phone calls and, answering our patients' questions. So I suggested, let's use our EMR for help, like, put in reminders, we're putting in that follow-up, but everyone is in that tenuous space that that's just one more work task to add to the day. So I came in today like, okay, today we're going to talk about it again, and I'm going to be a better listener instead. But this is, I don't even know. I would love to hear you guys, because I know that my clinic is not unique to that challenge. So I would love any feedback on that as well.
Anybody have any thoughts for Amber?
Hey, Amber, this is David Blessing. I've experienced some of that as well. So for this project in my office, what I've done is I've empowered the staff to, especially new patients for hypertension for us, to identify them to me when they come in. And that way we have a conversation with them and talk about control and, put in place how we're managing this project. So it gives a little buy-in from the staff, and it's been very positive so far. They've been really helpful.
Any other thoughts for Amber? So I will just add, Amber, I think, you're thinking about this correctly, like, and I'm glad this presentation is helping you think about that. But also, some of it is, it's managing expectations of your staff and of the patients. So if the patient's expecting a response back immediately or expecting you to answer the call, and it's probably not just that one patient, there's probably other patients who feel that way too. So what can you do to, manage their expectations? That's the first thing. And then thinking about, what's going on with your staff. Having contentious discussions are not necessarily bad things. Like a lot of times, you can uncover why people are resistant to change and what their issues are with the process. And, really doing some active listening with the staff to find out, okay, what can we do to improve this process? And it sounds like you're already starting to think about that, right? So what can I do to improve the process? What can I do to improve, my staff satisfaction? Because let's be honest, that's really important too. We don't want staff to be burned out or leave or things like that. And then getting at, and I'm going to go over this in a minute, what's in it for me, right? So that's not insignificant to the staff. Why should they want to be engaged in this process? Why is this process so important? And maybe it's getting at, how it impacts them personally. Do they know somebody who's been impacted by long wait times? Or do they have similar frustrations when they call their providers? Understanding all of those things would be really helpful for you in improving this process. In the interest of time, I think we have to move on. Okay, so this is the what's in it for me slide. Dr. Peter Pronovost from University Hospitals has done a lot of work in this area, and he's got some principles about how he thinks about what an adaptive leader, qualities that adaptive leaders emulate. The first one is be unwavering and invite help. Set a clear and achievable goal, involve all stakeholders, and build collective ownership. So if we're thinking about cardiovascular disease, we could talk about reducing readmissions for heart failure. Strategy might be involving primary care, cardiology, case managers, community health workers, and patients in co-designing a discharge follow-up process. Your outcome might be regularly multidisciplinary huddles to improve follow-up rates and medication reconciliation. You want to surface real and perceived losses. And this is some of the things that we were just talking about in Amber's example. Understand the emotional and psychological concerns and create space for open discussion, which that's a great quality in a leader, Amber, that you invited that open discussion and you weren't afraid of, people who may not necessarily agree with what you're doing. Finally, you want to communicate the need for change, right? Explain the why clearly, avoid assumptions or surprises. You want to tune into the what's in it for me. That's really, really important. Identify what motivates staff. Is it time? Is it autonomy? Is it that they're personally invested in some sort of, that they've been personally affected by something? And you could pilot something small. So one of the things you could do is, if I'm going back to that example of reducing readmissions, nurses hesitate to do CVD risk screenings due to time constraints. A small pilot could add a screener and triage and reduce total documentation time. And realize that, this could prevent misdiagnosis and save rework later. So if you're talking about workflow, that's how you can get into some of the, the issues with staff that, it's too time intensive to do some of these things. You want to seek to understand and not judge. Talk to resistors instead of labeling them. Address hidden concerns or barriers. So if a medical assistant was labeled difficult, wasn't completing lifestyle counseling forms after a conversation, maybe they felt like they weren't comfortable or prepared to have those discussions with patients. And you could do some quick training and figure out, how to really engage them in this process. And a lot of times then they become the most engaged people in the processes because they feel like they're, that they've been heard. Next slide, please. So other ideas are you could use patient advisory boards, redesign team roles, use community health workers or pharmacists to support medication adherence, create feedback loops to learn from patients who don't meet goals. What's getting in their way? Next slide. Okay, so before we get started on this video, these are two different perspectives. It's called the balcony and the dance floor. And this represents, the dance floor really represents being immersed in the action where real-time decisions and interpersonal dynamics and daily challenges play out. The balcony is perspective when you take a step back. So I want to share this short video with you, and then hopefully we'll have time for a quick little follow-up afterwards.
You might need to hit share computer sound.
Is the sound not playing?
Sound's not playing.
Yeah, like if you hit share computer sound, I think you have to go to I don't know what little.
If we can't do it, it's not that big of a deal. I can describe it. if it's not working, Andy.
Hey, Aleece, can you open the YouTube link directly or not? Just click double in a separate window.
Andy's running the slideshow. so-
Oh, okay.
Yeah, I just clicked
There we
share
go.
computer. You can hear it?
Yep.
Yep.
Let me start over.
The concept of the floor and the balcony is a great way of thinking about adaptive work when you're a manager. When we're in the middle of the dance floor and we're bumping elbows into everybody, we're in the middle of everything and we don't have a good perspective of what's really going on. We tend to spend a lot of time on the dance floor, in the middle of the action, moving from one thing to another. Managers need to go up on the balcony and look down on the dance floor to achieve the desired results. From this view, you can see everything, and you can look at the systems and patterns about what different groups and people are doing. We spend most of our time on the dance floor because sometimes we're afraid of the balcony and we want to get things done. Or it could be because old patterns pull us back into our previous roles. If you stay on the dance floor all the time, you will never get that broader view. Beaming yourself to the balcony and looking down on what's going on helps people change their course of action and try something different. And there are also times when you need to take your team members up to the balcony. This will help them get a bigger picture and see how important their role is in all of that. A few questions to reflect upon. How much time are you spending on the dance floor versus the balcony? What keeps you on the dance floor? What needs to change in the way you manage your people so you can spend more time on the balcony? Just think.
So one of the reasons I really like this video is because I tend to get stuck on the dance floor a lot. And it's, you have to really be cognizant about taking a step back and getting up on the balcony. This is really important for an adaptive leader to really toggle between the two views, because you can't lead effectively by staying in only one. So when we're thinking about it in terms of QI, like a dance floor view might be managing patient flow or EHR documentation challenges, implementing new care protocols, participating in team huddles, PDSA cycles, or tracking metrics. An example might be a provider sees a new diabetes screening protocol and is creating more work and disrupting visits. They're on the dance floor responding to their operational reality. If you get up on the balcony, the leader might realize the protocol isn't failing because it's poorly designed. It's because the frontline staff wasn't really engaged in the workflow, or it's not aligned with the clinic's capacity. So when you're thinking about, when you're implementing something, you really need to take that step back. You have to think about when you want to get directly involved. Think of, and you're gonna have to get a little bit outside your comfort zone. I feel like a lot of us are really comfortable in that dance floor perspective, and that the information we gain is insightful, but what kind of activities require you to be on the balcony? Being a little bit uncomfortable on the balcony is okay. And here's and I've added some other questions that you might consider, and I think I'm almost out of time. So if we could just move forward, because I don't want to take time away from Gotham. Just skip that slide, Andy. So the key takeaways from this is not all challenges are technical. Many barriers to better cardiovascular outcomes require adaptive solutions. Adaptive leadership really helps us understand the deeper why behind performance gaps, engaging both patients and care teams more effectively. But the balcony perspective is really essential. You want to identify patterns, resistance, and opportunities for true change. Use team-based approaches to share the work and build ownership, nurses, MAs, pharmacists, etc. And progress requires persistence and curiosity. So, you have to keep asking yourself, what's really getting in the way of better outcomes? So, you might be really, really engaged in your process and you're not seeing improvement. So why is that? You've got people who are working really hard. They really want to see improvements in their blood pressure or their diabetes outcomes for their patient populations, but they're not seeing those gains. So it's taking a step back and examining some of these assumptions and patterns is really, really important. I don't think we have time for questions because I think I am over time. And I think I'm turning it over to Gotham now.
Thank you, Aleece, and thanks for everyone. And I'm just periodically, I was texting to Claire, I may have to go off camera because neither Wi-Fi nor cell service is strangely available here in Brooklyn, which is odd. I think it's just the hotel I'm in. Anyway, so we're going to start a lot of these sessions with a clinical pearl. We're not going to review all sorts of guidelines, but since blood pressure is a major part of what we're going to be talking about, and many of you are focused on in terms of your project, let's start with this particular scenario. So it's a 63-year-old man has had uncontrolled stage 2 hypertension for the past 2 years. He's taken amlodipine and chlorthalidone. He has no other cardiovascular risks nor any kidney disease, nothing else, doesn't smoke. BMI is 25, not too bad. He's come in 3 times in the office, let's say on 3 separate days, 2 readings each time. He's averaging 160 over 100. Before you look at the AHA's algorithm to the right, and I will tell you that the AHA guidelines for kidney disease, cardiometabolic kidney disease, and obesity are being consolidated into one since there's so much overlap. I am on the guideline committee, and our recommendations will probably be ready and published, I'm guessing, in about January 2026. But based on your clinical experience, what would people do in this situation?
So I think one of the first step that needs to be done is identify what's causing this hypertension that requires multiple medications. So maybe look into the reasons why there's treatment-resistant hypertension. So maybe do aldosterone-renin ratio.
Yeah, that's a possibility. So Jim, you're suggesting further investigation. Anybody else?
Hey there. It might not be the ideal combination of medicines, and that's assuming that the patient's actually taking them.
Yeah, so great points, Mike. So I think those are, yeah, so both of you had said something I think that was very, very sensible. And you'll notice in the AHA's algorithm, yes, we've got this gentleman on a couple of first-line agents. He's on a calcium channel blocker and he's on a thiazide diuretic. You'll notice the second phase is to measure, use fixed dose combinations and looking into adherence issues, which Mike has suggested. Then look at social barriers, non-adherence to treatment. Looking at renal ultrasound, various other things, renin levels, etc. Probably not useful. So the point here is don't just add a third agent. Let's look into exactly what's going on. Now, I'm a big advocate of ABPM, 24-hour ABPM, for example. And you could do it for just 24 hours or even for longer than that. And looking at what the specific pattern of blood pressure is. So you want to make sure it dips at night. So if he's a non-dipper, he's at extremely high risk of cardiovascular events, for example. And you will get to some parameters such as the mean systolic blood pressure, the mean diastolic blood pressure, and the systolic load is very important. So the percentage of systolic values that are above a certain percentile, ABPM values are different than manual values in the daytime. And if that's high, then he's at high risk. So those are all the right answers. Do not just simply jump to a third agent. Adherence is probably the first, as Jim said, is probably the first thing to do. Okay, so that was the clinical pearl. Any questions about that? And this is not likely to change with the new guidelines, by the way, that are coming out next year.
Yes, this is Arpita.
Yeah.
Thank you for the presentation.
Mhm.
So if we go through the history with the patient,
Mhm.
I agree with you, like, not to add the third agent, but at the same time, there is clinical pressure from, like, you
Yes.
saw the patient and the blood pressure is 160, you didn't make any change, and then they do, like, random data, and they say,
Mhm.
like, you're not addressing your patient's blood pressure, and they don't
Mhm.
follow up, then what's the problem?
Yeah, excellent point, Arpita. So quality measures always have some sort of way out, right? So for example, this is a very simplified example. I wanted to add a third agent, but the patient refused, or patient reports side effects, couldn't do it, or investigated other options. So I think that as long as you address the issue, first of all, the biggest problem is that this man is coming in with stage 2 hypertension over and over again, and nobody is doing anything. Nobody's investigating, nobody's asking him about adherence, nobody's thinking about changing agents. That's not good quality care. But as long as you're doing something, I think that it's unfortunately in some system it's very arbitrary. Look, the blood pressure is uncontrolled. Well, you can actually refine that assessment a little bit by looking at some of these nuances, especially those that deal with adherence. If somebody were to start a third agent, what would you start, just out of curiosity?
ACE inhibitor.
Yeah, I would, go with an ACE or an ARB. What I would do, and this is just me personally, is I would continue them on the chlorthalidone, and I might do a combo ARB calcium channel blocker. There's olmesartan amlodipine combo, which is quite effective. So that's probably what I'd do. So I'd probably do the same thing as Arpita. Anybody do anything different?
And one other thing about the uncontrolled hypertension, like this patient has no cardiovascular risk, but I would have screened him for sleep apnea if
Yeah.
that could be one of the reasons for that.
Yeah, so looking for secondary causes. So this goes back to the basics. Why do we assess blood pressure when somebody comes in? We first of all, we assess additional cardiovascular risks that address secondary causes of hypertension. That's the second goal, and target organ damage is the third goal. So I measure his lipids because it's an additional cardiovascular risk. I'm looking at obstructive sleep apnea as a secondary cause, or excessive alcohol consumption, whatever it happens to be. And of course, I'm doing renal function, etc. Maybe electrocardiogram to look for LVH, etc. Just to look at the damage that's taken. So that is one option as well. So I think the lesson here is, if somebody is in this state, take a deep breath, pause, think about why this is the situation before proceeding. So Andy, next slide. Okay, so this is where you get to apply a lot of the things that Aleece mentioned in terms of adaptive leadership, and actually the why of this why the outcomes may not be the ideal. So let's say we are at St. Hugh's Internal Medicine, 8-physician practice in Sandusky, with a diverse patient population. It wishes to build a QI team to tackle uncontrolled hypertension. Preliminary review of adult patients with hypertension in the practice based on EHR records revealed that roughly 55% have uncontrolled. That's stage 1 or higher. Now, stage 1 is 130 over 80 is quite low, but stage 2 is a quarter of the people. These are people with hypertension who are established in the practice, which means by most definitions, they have at least 2 visits a year, they have an assigned primary care provider, etc. Your job is to improve that particular rate of control, which is only 45% right now. So the questions I have for you as you think about this, and you don't have to answer them all in sequence or all at once, who should be on your QI team? What challenges and adaptive strategies do you foresee taking on to address the problem? How might you tackle the problem? How might you get started? And what are the realistic outcomes over what specific time frame? So let's throw out and see if any of you would like to address one or more of those questions.
So the people on the QI team, I would recommend starting with the frontline staff, nurse coordinator. Of course, the patient is the first one to be on the leadership, and then the clinician and I mean, like the clinic chair or like whoever is responsible for
Mhm.
the QI at the clinic. And the anticipated technical and adaptive strategies is basically technical, having a reminder and having a doorstop sign saying like, this patient has high blood pressure, repeat the blood pressure thing. And then adaptive strategies has to be training with new clinical guidelines for the patient, sorry, not for the patient, for the clinical staff, and including the MAs and the nurses. That will help them to address like multiple people addressing the same issue encourages the patient, I guess. And also like having monthly review process on it, and
Mhm.
going through the process setbacks and see where the problem is coming. And to add to the QI team, I would also think pharmacy.
Okay.
Yeah.
Sort of a pharmacy who's connected to the project itself. That's a good idea. Okay.
And
So, yeah, go ahead, Arpita. Sorry.
how might a project to tackle the problem get started? I'm not sure about it. Sorry.
Yeah, that's okay. So, I mean, you gave us some great information about who should be on the team, and I think that just based on Aleece's presentation, you want a diverse range of stakeholders saying, "Hey, you can call it. You can even call the project something, improving blood pressure in Sandusky or whatever." And you mentioned the frontline staff, which are critically important. If they're not invested in it, it makes it difficult. They tell a patient you've got uncontrolled hypertension. They should reflexively, based on some protocol, say, hey, you need to come back soon so we can measure it again. Or, this is a really important issue. Maybe reinforce some of the information that they may receive from a clinician, for example. So those are all very important. You can have patients on a stakeholder panel as well. Um, the technical and adaptive challenges, strategies, I think, are really, really important. The why is it uncontrolled in so many people? The right thing to do is not to blame the clinicians or the practice entirely. It's a combination of factors. Nobody is specifically to blame. It's failures on multiple levels. But let's throw out that third question to the group. How might we get started with this?
So, Dr. Rao, to contribute to the answer to this case discussion. So, the people that needed to be on the QI team is, of course, the resident physicians and the MAs that get the vital signs, and then the anticipated technical and adaptive strategy. So, the technical, the in that aspect. So, we really have to know the. Again, you have mentioned it earlier that compliance is a very important thing that we have to look into, because it doesn't matter if the patient is taking 2, 3, 4, or even 5 medications. If they're not compliant, their blood pressure is not going to go down. So it's one thing that we need to be asking our patients about: are you taking your blood pressure medications, or any medications for that matter? And then in terms of addressing the problem, of course, once we have identified what the problem is, then we can address the solution. Then we can provide solution, because after all, if we don't know what the problem is, then we can't provide any solution to that one. And then the realistic outcomes is that in terms of course, targeting the blood pressure, we want to lower the hypertension down as much as possible. But then in terms of monitoring, so aside from clinical measurements, so they go to your clinic, you measure the blood pressure. Some patients, they may be having white coat hypertension, but it's also important to stress out, hey, did you write down your blood pressure at home in the morning or in the evening? So did you bring your list? And then we can go over that, because that's also one of the parameters that we consider in terms of establishing our goal of hypertension treatment.
So those are all great suggestions, and they're all part of the clinical strategy to improve blood pressure. But how would you start? Where would you start with all of this? You've put together a team. You are anticipating some challenges. You've thought about some adaptive strategies, but where would you start? Let's say your goal is to start July 1st. What would you do?
So, um, so in terms of addressing hypertension, I mean, it's not, it takes time for this one. So, we have to identify the patients in our chart who
Good.
has been diagnosed with high blood pressure, and then we assemble the team. We identify that, tabulate everything, and then prescribe the medication or make adjustments with medication, and then track them over time. So ideally, it's uh, maybe a month, just to, especially if they have like hypertensive urgencies, for that matter, you want to be more vigilant in those hypertensive urgencies, because you don't want them to escalate into, ending up in the emergency room suffering a stroke. So it's more of like a close monitoring vigilance. So yeah, the timing for that one is more a closer visit. So yeah, we have to get everybody involved in terms of that one, because again, high blood pressure is very important.
Yeah. So yeah, go ahead, Arpita. Go. Sorry.
Just to add, with what he was stating, like, getting the data and assembling the team at least 2 to 3 months ahead of our start date will guide us, like, whom to target first, and like what are their setbacks, going through each patient chart, specifically looking into seeing like when did they follow up, did they actually still connected with our system, and is the patient still like alive. There are multiple factors to dig into the data, and then targeting the problem might help to focus on improving the um, percentage of the realistic outcomes.
Great. Mike, did you have your hand raised still? I'm sorry if I missed you.
Yeah, I was thinking one place that I get started is I have the core team together and we're looking at this problem. I would look at other blood pressure improvement or hypertension improvement endeavors that have gone well, and look at, did they adhere to like some core set of processes that they worked on improving? And then I would look at, okay, well, which of these makes sense for us to tackle, and then figure out, did we miss anybody? So if one of the core processes was something that we don't really have a team member yet, we need to get that person on board, and that might help us kind of answer the question as to how do we want to apply those proven techniques, such as early follow-up for elevated blood pressure. How do we actually do that?
Yeah, so those are all outstanding suggestions and very highly aligned with what's been done before, as Dr. Holliday said. So I was involved in a project like this in Chicago many years ago, and it was interesting. All the stage 2 hypertension people would say, well, my blood pressure is normal at home. I don't know why it's so high when I come here, which of course we've all heard before. So we bought a machine called a BP True. I don't know if you heard about it. It takes 6 readings in 5 minutes and throws out the most extreme one and gives you a more accurate blood pressure value. They're not terribly expensive, but it turned out that we didn't have such a high rate of stage 2 hypertension after all. And those that we were able to target, I think Arpita and Jim both mentioned, when you sit down with your team and look at a list of people who are out of control, you'd be surprised who chimes in. It may be the MA that never says anything that says, oh, I know that guy. He never takes his medication. That's why. It was, oh, well, that's really helpful. I mean, it's incredibly helpful. He always claims to. He tells you he takes his medication, but when he leaves, he doesn't fill his prescriptions or whatever it happens to be. So I think that the entire team can be extremely helpful. So as we are quickly running out of time, let's talk about outcomes. So we are saying that right now, 45% of the people with diagnosed hypertension who have regular source of care in this particular practice have controlled BP, meaning 130/80 or less than 130/80. And 25% are stage 2, so they're over the 140/90. What's a realistic outcome from all of these efforts? And I think, as Arpita said, you have to give this time. You plan a few months in advance. One of the biggest mistakes I've noticed in QI is people being extremely ambitious. There was one guy I worked with who said his goal was to reduce his uncontrolled rate to 0 which of course he didn't achieve, but he was very passionate about caring for his patients, obviously cared a great deal about them. But what's a realistic outcome?
Having a small like number, maybe 10%.
Yeah. So you probably want to focus on the stage 2 hypertension folks, and maybe going from 25% to 10% in stage 2 over a year is realistic with all the processes in place. And you have to think about what's going to be driving that. Maybe you're starting with the people that have the highest average blood pressure. Maybe they have poor health literacy. Maybe the pharmacist needs to be involved to provide more counseling. Maybe we need to measure better, but that's a realistic goal. And having 10% of people with stage 2 hypertension that's uncontrolled is not bad. And of course, your stage 1 is going to come down as well because you're implementing the same interventions across the board. So that's a realistic goal. Okay. Anyone have any further thoughts about the target or the outcomes? That's the clinical target, but let's talk about some of the intermediate outcomes and process measures that we might think about too. Okay, so what kinds of other things would you want to see? Just process measures. So the clinical outcome is highly dependent upon so many different factors, right? So, but what is the process and how would you measure it and how would you make sure you're adhering to the process?
Doing a process mapping.
Sorry, there's two people on at once, I think. Go ahead.
Doing a process mapping and like finding our like either a fishbone diagram or like trying to find where the hard stops are and trying to go through the process with the whole entire staff to see like what their opinions and suggestions can be included.
Yeah, I think that's an excellent approach. So patient walks in, we know that they have uncontrolled hypertension. What happens next? The MA measures the blood pressure, it's high. Okay. Does she or he or she take it again? Maybe not. Maybe there's no second measurement. So one step in the process might be if blood pressure is over a certain level, measuring it at the same visit within 10 minutes one more time. And then perhaps what's going on in the actual encounter with the physician, are they acknowledging this? And do they have a means or a strategy for treatment intensification or counseling or assessment at this point? Maybe they don't. So that process map can give you a very, very good picture of it, looking at some of these points. Based on that, though, what would you anticipate would be useful process outcomes, though? Either Arpita or Jim or anybody.
So so the process outcome, Dr. Rao, for this one. So again, so it is highly important to track these patients down in terms of setting up when they visit the clinic today. Before they take off, we have to discuss again compliance and then emphasize the next follow-up visit so that we can track down their blood pressure. And then aside so yeah, so setting up that next follow-up visit, taking it, noting it so that once they come back, we know that this visit is all about tracking blood pressure. Because again, in the heat of the battle, when we're bombarded with lots of patients, sometimes we lose track about, oh, okay, so you're here for A1C measurement, and then things fall through the cracks. So it's highly important to take note about these things in today's documentation so that when the patient comes back, we know what to measure, we know what to anticipate.
Yeah, that's excellent. So here are my thoughts about that. So what Jim is saying is that they need to come back. There's no way that you are going to improve the quality of care for these patients unless they have a discharge of uncontrolled hypertension follow-up in 2 weeks. Now, what happens when they come back? It could be all over the map, right? It could be the clinician is intensifying treatment, they're measuring it several times, they're doing more of an inquiry, etc. To confirm what the underlying cause might be. They may be ordering additional investigations. Whatever you do is going to be an improvement over the current state. If they don't come back, this is, as a pediatric hypertension researcher, I can tell you, in the office, you need to have 3 separate readings on different days. And in the pediatric world, many people don't come back. Many of these kids don't come back for whatever reason. So you never get a diagnosis. So much of it is undiagnosed. This is a similar situation with these folks. If they don't come back, you're not going to get anything. So an extremely useful process outcome would be the number of percentages of these people who return within a specific time frame. Okay, any additional process outcomes you think would be great?
How about at least 2 blood pressure measurements
Good.
when the initial one is elevated?
Yeah, excellent. So that often happens. It's high. The physician is relying on this. They may not have time, but maybe the second one is a little bit better. So you've got to do at least 2 at each visit for sure. Those are 2 very, very important ones. And then there are the more sophisticated process outcomes. What percentage have intensification of treatment? Okay, and additional medication, what percentage have investigations, etc. I think those things are a little bit more subtle because sometimes you don't want to intensify treatment. And we were just talked about the previous case, you want to go in a slightly different direction. Okay. All right. Any thoughts from the rest of the team before we wrap up today?
Gotham, Steve Grossman.
Go ahead, please.
I know this is soft science, but I had a partner who used to occasionally walk into a situation like this, acting like he had had a stroke, and he'd play that out for 30 seconds. And then they'd say, "Oh my God, Dr. So-and-so, what happened to you?" And he'd say, "This is what I don't want to have happen to you." So the idea of really engaging with the patient, showing them what might happen if they they weren't compliant and if they didn't come back and so forth. You know, we've got to connect with these people. We've got to make them realize how important this is for us and for them, that we're going to partner with them. I'm stating the obvious, I know, but at some point, you know, just to say, here, do this, they need to buy in. And I think everybody in the audience obviously knows this, but I'm just repeating the obvious.
Yeah, no, I agree with you, Stephen. I think you know, educating the patients is very important. This is the silent killer. A lot of these folks don't understand its implications. The majority of my patients are older African Americans. Many of them already have established heart disease and strokes. And you say, why do you want to add another medication? Because I don't want you to wind up like somebody that you definitely know in your family or friends or someone else who's had a stroke. And that does have some impact, I think, on how we're thinking about things. But great suggestion. Okay, I think if there's nothing is there anything from Aleece or any other member of the team that?
So since we ran out of time this week, we are going to allot extra time next month for project updates. Otherwise, our few reminders, a post-clinic survey will be sent out to you. You should have already received it. You can complete that by tomorrow. That'd be great. A reminder that your data is due tomorrow for March, April, and May. And then your next data will be due July 8th. And then due to the holiday, we'll be moving our next month series clinic. So it'll be July 10th from 8 to 9 rather than the 3rd.
Thank you, Andy. And I'm sorry to run out of time for updates. I hope you guys are all getting started. We are receiving data. We've met, Amanda has met with the teams. I've met with some of you as well. Great ideas. And I hope today's session was helpful for you. Enjoy the rest of your day. Bye-bye.